the Pegg. I'm a Senior Research Consultant in Environmental Sustainability and Health Technology Assessment. That's a mouthful at this time of day. So in a nutshell, it's my job to try and get environmental outcomes into the HTA decision-making process. Health Technology Assessment is what NICE does. So I was running, down to SSD, trying to get things sterilized in time for a trauma case. So I've done a lot in surgery. Okay, so I must have been feeling rather adventurous with this title when I decided to submit this presentation. But in a nutshell, I'm about to present to you a case study on surgical waste and waste segregation. So I went rummaging about in some waste bins and had a look at what waste was in there and reported it. I noticed a good few years ago that there wasn't really an awful lot of data on what was in waste bins in the surgical operating room, and in particular in the clinical waste. I knew there was a lot of it because I'd seen hundreds of surgical operations and so much waste. So it was really important for me to choose this as a topic when I was studying my Masters in Sustainability with University of Derby. Okay, so some facts, because hopefully you'll find them quite interesting. There's over 10 million surgical procedures each year in the NHS, which is an increase of 40% from 2005 to 2006. Staggering, isn't it? We'd want to try and keep people out of hospital, try and keep people healthy, good diet, exercise, stop them having to have surgical interventions in the first place. Yeah. Studies report the burden of waste generated by surgery accounts for up to 70% of a hospital's total waste volume. So this absolutely needs to be a focus for research. This statistic, I can imagine, there's a lot more waste produced in the NHS, because at the time when I was researching overall how much waste is produced in the NHS, this study reported that only 2/3 of NHS trusts reported their waste volumes for this report. So it's wildly underestimated, more than likely. But at the time, 2019, we don't have NHS Digital anymore, reported the NHS in England generates approximately 538.6 tonnes of waste per year, contributing approximately 6% of the carbon footprint of the UK emissions. So surgical care is a major area of resource consumption, lots of waste, lots of resource consumption, lots of spending, with the carbon footprint of surgical care in the UK NHS estimated at 5.7 million tonnes of CO2e per year. So my study that I'm about to come on to, I found that approximately 96,000 total hip replacement procedures weighing approximately 11 kilos of waste per operation generates about 1,043 tonnes of waste per year, just for that single type of operation, large joint arthroplasty. Another fact which I found interesting to share with you is that an analysis focusing exclusively on the products used in 5 commonly performed operations found waste disposal was responsible for about 9% of the carbon footprint. So more about single use. There's been a disturbing trend towards using single-use disposable equipment over the past 3 decades in particular, and this is rapidly increasing. Simple devices such as blood pressure cuffs, pulse oximetry probes, as well as complex devices such as laryngoscopes, laparoscopic equipment, and rhinolaryngoscopes, which is my case study I'm about to share with you, may now be single-use. Bearing in mind, a lot of them have been reusable before. I've been around long enough to know that. Review of single-use reusable gowns, so PP is a huge generator of carbon footprint in surgery, found that reductions in carbon footprint could be achieved if using reusable over single-use PPE of up to 300% for using reusable. So a reduction in 300% of carbon footprint of reusable compared to single-use, a reduction in water footprint of up to 330%, and waste generation reduced by up to 750% if you use reusable PPE over single use. Crazy. Rizan in 2020 reported the choice of waste stream has up to a 50-fold impact on a procedure's carbon footprint. So, sustainable development in healthcare, and I'm going to keep this brief. So my area is health technology assessment, so pharmaceuticals, medical devices, public health interventions, digital health technologies, evaluating them, look at the cost effectiveness, looking at budget impact, then looking at environmental outcomes as well, and social factors. So all of that needs to come together at some point. We're already, there's a lot of people involved in HTA. You've got industry, you've got health economists, you've got researchers, you've got the NHS, etc., all wanting different things out of that decision-making process. But ultimately, we all really want sustainability because we're on the same planet. So traditional HTA needs to adapt its methods. I did go through some health economics very briefly this morning. Very traditional way of looking at measuring health and cost effectiveness. And it's unlikely that that framework is going to change anytime soon. So what can we do in the meantime? Because we don't have the luxury of time. So this is a beautiful figure, which I'm sure all of you are aware of in this room. But from a sort of sustainable surgical perspective, the top of the ranking for this hierarchy is surgical disease prevention. It's not new news. Keep people healthy, keep people out of surgery, and so forth. But there's a lot that can be done with low-carbon alternatives across the whole surgical care pathway, reusables, which has been spoken a lot today, and then those reusables to be maintained and repaired to keep them in use for as long as possible. The infrastructure is obviously important from that perspective as well, so each healthcare facility differs in their approach to that. In my previous role as a fellow for the British Medical Journal, working on the first Net Zero Commission, I co-authored the report that was published in November last year in sustainable surgery, green surgery. So that's screening the whole entire care pathway from keeping people healthy all the way to post-operative care. So I did a lot on intraoperative, reducing the carbon impact of surgical devices that are used intraoperatively. And there was a huge amount of support from our healthcare professional colleagues. They are doing so much to try to change the way that they use different, I'm losing my head now, I could do with some coffee. the different healthcare practices in terms of sustainable development. So they really want to use reusables. They really, really want to adhere to, for example, the Green Theatre Checklist. That's a fantastic piece of guidance that it's an intercollegiate piece of guidance from the Royal Colleges of Surgeons that came together to work on producing a compendium of evidence, and a very thorough compendium of evidence, and this checklist, which very much promotes more sustainable surgical practices. I won't go through this, because it's already been touched on very nicely in terms of circular economy. So my research then, which was published in 2022, was to examine current waste management practices of total hip replacement procedures. The study measured the volume and type of waste produced, so waste segregation, waste volume, and then when I was looking in the waste, I thought, my goodness me, look at those single-use devices which used to be reusable. Why can't we just change them back to reusable? So the research aimed to highlight the burden of the waste produced by that particular type of surgery. So I undertook 3 waste audits across 2 orthopaedic surgeries within Newcastle Hospital. To obtain real-world data, the staff agreed to manage the waste as they normally would for each operation. So I was there during the operations, and I watched them put the waste into the bins, and then I weighed them after, and I went through all of the waste. And I've worked with the National Joint Registry in the past, so I was really keen to extrapolate this data to find out how much waste is produced per year by total hip replacement procedures in the UK. So it became very clear during surgery A and B that the staff were putting a lot of clearly recyclable waste, so the packaging from the implants, into the clinical waste. And I knew why, because I've worked in hundreds of surgeries, that as soon as the knife goes to skin to open the patient, then all potential recyclable waste can't be put into the recyclable waste stream. It needs to be put into clinical waste for fear of contamination, even though it looked very clean. There was nothing wrong with it. I've got some pictures to show you that. So that was interesting. So I said to the staff, okay, for this third waste audit, for all that waste that you're going to put into clinical waste stream, can you just put it to the side for me so I can measure the missed opportunity to recycle that waste that's going to end up in the clinical waste stream? And that was very interesting results, so I'll show you that now. So the average average volume of waste per procedure was 10.9 kilograms, comprising of 85% clinical, 12% recycling, and 5% sharps. There we go. So all of this waste for one surgical procedure, including laundry. So I just have to say that to you, because that does bulk it up quite a bit, but still a lot. One surgery, 96,000 of them every year. Crazy. An example of the sharps waste from a total hip operation. One surgical procedure produces that much sharps waste. And an example of clean recyclable material deposited in the clinical waste. So I took a picture of this that had just been put in there from, I think, surgery A. Clearly, visibly clean. And I interviewed a lot of staff while I was doing this. So I did the quantitative analysis and the qualitative to triangulate the findings. I didn't include that in this presentation because it would have been too much data. But all the staff wanted to. It really depended on who was in the room and the so-called protocol that was being followed, although I never saw this protocol, but as soon as the knife went to skin, most of the operating rooms did not want, most of the people, the staff in the operating rooms, did not want to collect any more recyclable material. But in that in the third surgery, they were more keen to, so they did collect more. So an example of the recyclable packaging from the additional recycling. So this was what I mentioned when I modified the method for collecting the waste in the third surgery. This was what was going to go into the clinical waste stream, but I said just keep it to the side for me to look at and weigh. And as you can see, all of it could have been recycled. It's all implant packaging. Don't think Stryker would like me very much for showing that picture. Yes, so interestingly, if you add up those two, 2.6 kilos of recyclable waste potentially there could have been collected out of, so 10.2 overall, 2.6 potentially could have been recycled. And then extrapolating the data, which I love to do. National Joint Registry, probably one of the most robust registry pieces of data globally. So if you wanted to do this with any other types of surgical procedures that involves joint replacement, go to the NJR, get some data, find out how many surgical procedures they do each year, do a waste audit on the clinical data, have a look at the single-use devices that could be reusable, and change them back to reusable. So overall, if you look at the number of total hip replacement cases that the NJR reported for 2019 was 95,677, multiplied by 10.9 kilos of waste per operation, gives you the figure of 1,043 tonnes of waste for primary total hip arthroplasty procedures in the UK each year. This used to be reusable, single use. This requires 8 AA batteries per device. It goes into clinical waste. Absolutely bonkers, isn't it? And I've included costs in this presentation, but you could find that out and then easily do the maths to work out how much that's costing, and then find out how much a reusable device is and how long it lives for, and then divide that by the cost that it, for the reusable. That's called life cycle costing. I haven't heard that today, but it's something we really need to embed into environmental management reporting of health technologies. And that's a single-use surgical cement mixer. Bonkers. Used to be reusable. Single-use device contributed 5% of clinical waste per operation. So the burden is on the end user. That single-use device user, the burden of the waste is on the end user. The cost is on the user. I've pretty much been through all of this, but the demand for overall surgery is increasing. We need to remember that by about 5% a year, if not more. So it's only going to go up. If we keep using more single-use devices, there's more surgery, there's going to be more waste. Completely unsustainable. So future research and policy development. Recommend developing sustainable quality improvement projects. Oh, thank you. Audits and research products that consider environmental, financial and social sustainability. If you haven't worked with the Centre of Sustainable Healthcare before, they are amazing. See some nods in the audience. You can do like pilot studies, and I'm sure that you can use it for your personal development and CV and what have you. But those pilot studies are they're so valuable because it can end up rolling out across other departments in the hospital, and then before you know it, you get things like desflurane decommissioning happening, which, by the way, happened from hiding the desflurane in the cupboard at Newcastle hospitals when I was doing this. So that's it. Thank you very much for your time.